So since it covers the heart and the root of the great vessels, okay, the main function of the pericardium, it is to lubricate the surface of the heart. And it also prevents sudden dilatation of the right atrium as well as the right ventricle during exercise and hypervolemia. It also acts as a barrier to infection, mainly in cases of chest infection. Okay, so it acts as the barrier. It stops the spread of the infection. But however, congenital absence of pericardium does not result in any significant clinical or functional limitations. Okay, so we'll be starting with the pericarditis first. Okay, so clinical classification divides the pericarditis into acute pericarditis, subacute pericarditis, and chronic pericarditis, depending on the duration of signs and symptoms. Okay, so if the clinical presentation it is less than 6 weeks, it is acute. If it is 6 weeks to 6 months, then that is subacute, and if it is more than 6 months, then that is chronic pericarditis. Now, etiological classification divides this pericarditis into infectious, non-infectious, and pericarditis related to hypersensitivity and autoimmunity. Infectious causes includes different viral infections like Coxsackie virus A and B, ecovirus, mumps, adenovirus, hepatitis, HIV. Pyogenic infections include infection by pneumococcus, streptococcus, staphylococcus, Neisseria, and Legionella. It may be because of tuberculosis, and it may be because of fungal infections, because of infection by histoplasmosis, coccidioidomycosis, candida, blastomycosis, and it can be there in other infections like syphilis, protozoal infection, and parasitic infection. The non-infectious pericarditis are caused by conditions like acute myocardial infarction, uremia, neoplasm, myxedema, chylopericardium, trauma, aortic dissection, post-irradiation, idiopathic, and sarcoidosis. So there are some pericarditis which are related to hypersensitivity or autoimmunity. It may be because of rheumatic fever or following some collagen vascular disease like SLE, rheumatoid arthritis, ankylosing spondylitis, scleroderma, acute rheumatic fever, granulomatosis with polyangiitis, that is Wegener's granulomatosis. It may also be because of some drugs like procanamide, hydralazine, phenytoin, isoniazid, minoxidil, anticoagulants, and it may also be post-cardiac injury. After post-cardiac injury, like in cases of post-myocardial infarction, this is also called Dressler's syndrome, post-pericardiotomy, and post-traumatic. Okay, so this was the etiology for the pericarditis. Okay, so pericarditis means acute, subacute, and chronic pericarditis. Okay, so most of the clinical features of acute and subacute, they will be overlapping. So we'll be talking about acute pericarditis, chronic pericarditis, or chronic constrictive pericarditis. Okay, and since most of the patient with acute pericarditis, they develop pericardial effusion, we'll be talking about this acute pericarditis and pericardial effusion at the same time, okay, continuously. And the last topic being cardiac tamponade. Okay, firstly, we'll be starting with acute pericarditis and pericardial effusion. Okay, so this acute pericarditis, it is due to the acute inflammatory process which affects the pericardium, and most often it may coexist with myocarditis. And this acute pericarditis, it is the most common pathological process involved in the pericardium. Okay, so in general, we discussed about the causes of pericarditis, but for acute pericarditis and pericardial effusion, these are the commonest causes, okay? like for example, infections, mainly viral, bacterial, or tuberculosis, inflammatory because of rheumatoid arthritis, SLE, and rheumatic fever. Others include post-myocardial infarction, uremia, malignancy, and trauma. Now, the pathogenesis. Okay, all form of pericarditis may produce a pericardial effusion. So that this pericardial effusion may be the sequelae of pericarditis in most of the cases, and it depends on the etiology. The effusion, okay, this effusion fluid, pericardial fluid, it may be fibrinous, serous, hemorrhagic, or purulent. This fibrinous exudate leads to varying degree of adhesion formation, and the serious pericarditis produces a large effusion of turbid straw-colored fluid with high protein content. And hemorrhagic effusion is often because of some malignant conditions, particularly associated with the carcinoma of the breast and the bronchus, as well as the lymphoma. And purulent pericarditis, it's very rare and may occur as a complication of sepsis or by direct spread from any intrathoracic infections. Okay, now the clinical features. A patient of acute pericarditis may have chest pain. It is the most important clinical feature. This chest pain in acute pericarditis, it may be retrosternal, which radiates to the shoulder and neck, and is typically aggravated by deep breath, movement and change in position, exercise, and so on. And most of the time, since the clinical features, it resembles with the pain in myocardial infarction. Okay, so most of the time this acute pericarditis, it is confused with acute myocardial infarction, but we can differentiate it because pain is relieved by sitting up and leaning forward, and intensified or aggravated by lying supine or lying flat. Okay, so this is the differentiating points between the two. Along with that, the patient may also have low-grade fever. And the other very specific clinical feature in patient with acute pericarditis is pericardial friction drop. It is the high-pitched, superficial scratching and crunching noise produced by movement of the inflamed pericardium, and it is diagnostic of pericarditis. It is usually heard in systole, but may also be heard in diastole, and it is best heard with diaphragm of the stethoscope as the patient sits forward at forced in expiration. Okay? And if you see, okay, so in around 85% of the patient of acute pericarditis, this pericardial friction drop may also will be heard. Okay, so chest pain, we have to differentiate it from acute myocardial infarction, but there are some differentiating points along with fever and pericardial friction drop. Okay, so what are the investigations we'll do then? So the diagnosis, it is often made on the basis of clinical features and ECG changes. Generally, the ECG changes includes ST segment elevation with upward concavity. PR interval depression is a specific indicator of acute pericarditis, and later there may be T wave inversion, particularly if there is large degree of myocarditis. But however, this ECG changes, they evolve typically in 4 different stages. In first stage, there will be widespread ST segment elevation with concavity upward. It involves 2 to 3 standard limb leads and V2 to V6, that is second to sixth chest leads as well. And there will be reciprocal changes in lead AVR. In the second stage, the ST segment which was elevated, it returns to the normal level. In the third stage, there will be appearance of the T wave inversion. And in fourth stage, which generally occurs in weeks or months after the onset of pericarditis, the ECG, it returns to the baseline or the normal. Okay, so this will be the ECG changes, but you just have to know that there will be ECG changes of ST segment elevation with upward concavity. Okay, so if there is MI, there will be upward convexity. Okay, but if it is acute pericarditis, there will be upward concavity. And if it is acute myocardial infarction, the ECG changes will be there in the specific leads only. But in cases of this pericarditis, generally we get the ECG changes which are generalized. Okay, it will not be lead specific. The other test we do is echocardiography, which may be normal if the patient only has pericarditis, but it may reveal pericardial effusion as well. Okay, so this is the ECG of a patient showing pericardial effusion. You can see that this is ST segment elevation with concavity upward. Okay, so concavity upward. So this is the ECG changes in a patient who has acute pericarditis. ST segment elevation with concavity upward. This is the ECG change in a patient who has acute pericarditis. Okay, so what do we do for treatment? Generally, there is no specific treatment for acute idiopathic pericarditis, but there is often role for aspirin. Okay, so the pain, it usually responds to aspirin 600 mg 6 times daily. Okay, but if aspirin it is not effective, other NSAIDs, okay, non-steroidal anti-inflammatory drugs like ibuprofen and indomethacin can also be given. This ibuprofen, it can be given in the dose of 400 to 600 3 times a day, and indomethacin, it can be given in the dose of 50 mg 3 times a day. In a patient who responds to these drugs, okay, so the drugs, it should be at least continued for 1 to 2 weeks, and the dose should be tapered over several weeks. Okay, so the first thing that we give for relief of pain is aspirin. Otherwise, we can give other non-steroidal anti-inflammatory drugs. But in patient who does not respond to NSAIDs, there is role of colchicine as well. So it has been found to be effective, as well as it reduces the risk of recurrence. Okay. So for the relief of pain, as well as for the um, uh, for stopping the recurrence rate. Okay, so this colchicine, it has a role. The other medication that we can give in a patient who has acute pericarditis is glucocorticoid. Generally, we give prednisolone 1 mg per kg per day, which suppresses the symptom in patients who fail therapy with anti-inflammatory drugs. But we have to be very careful when we are giving this drug, steroid, because there is chances that it increases the risk of recurrence. Okay, and in these patients who has acute pericarditis, okay, anticoagulants should be avoided as it can cause bleeding in the pericardial sac, and this can lead to pericardial cardiac tamponade. Okay, so we have to be careful when we are using other drugs like anticoagulants. In viral pericarditis, recovery usually occurs within a few weeks, days or weeks, but there may be recurrence, that is called chronic relapsing pericarditis. Purulent pericarditis requires treatment with antimicrobial therapy, pericardiocentesis, and if necessary, surgical drainage. Okay, so in cases of purulent pericarditis, okay, surgical intervention as well as pericardiocentesis may also be required. Okay, so what will be the clinical presentation if the patient develops pericardial effusion? Okay. So all the features that the patient has when a patient has acute pericarditis will be there in these patients as well. But there will be some changes in the physical signs as well. Okay, so what are the physical signs whenever a patient of acute pericarditis develops pericardial effusion? Okay, so with the onset of effusion, the heart sounds, it may become quieter. Apical impulse may disappear, and a friction rub, if present, may diminish in intensity. It is because of collection of fluid in the pericardial sac. Okay, and we can also get this Ewart sign. Okay, so Ewart sign, it is a patch of dullness or increased vocal fremitus or egophony beneath the angle of left scapula as the base of the lung is compressed by the pericardial fluid. Okay, so this dullness and percussion, increased vocal fremitus, egophony, these are the physical findings that we get in a patient who has consolidation. Okay, but even if the patient does not have consolidation, if a patient has pericardial effusion, because the pericardial fluid, it compresses the base of the lung, there will be development of these signs, okay, over the angle of the left scapula. This is called Ewart sign. And there can be changes in the symptoms as well, because the patient will have sensation of retrosternal oppression, okay, constriction like thing, okay, and pericardial tamponade can also be there. Okay, so what is it then? So while most this effusion do not have any significant hemodynamic effect, a large and rapidly developing effusion may cause cardiac tamponade, where the patient develops acute heart failure due to compression of the heart. Okay, so because of large amount of fluid that is accumulated in the pericardium. Okay, so the patient develops features of acute heart failure due to compression of the heart by the pericardial fluid. Okay, so this is called cardiac tamponade. And typical physical findings are marked rise in JBP, hypertension, and pulsus paradoxus. Okay, so any one of you, do you know what is pulsus paradoxus? Pulsus paradoxus, anyone? Pranisha, Pranisha Neopani, Janice,
Yes, ma'am. It is a
anyone?
abno- it is a abnormally large sound which causes decrease
Abnormally
in volume.
decreased volume, but
इंस्पिरेशन में
in
पॉल्स
which
एब्सेंट
phase
होने
of
मैम
respiration? Pulse क्यों नहीं?
इन्स्पिरेसनको बेलामा
Inspire.
सिस्टोलिक प्रेसर 10 मिलिमिटर मर्करी भन्दा कम घटेर
Okay,
पल्स फिल नहुने के
okay, good. Okay. So generally, what happens is um, there may be fall in the pressure of less than 10 millimeter of mercury during inspiration. Okay, so this, there is nothing paradoxical about this pulsus paradoxus. Okay, so there will be fall in pressure, but it will be more than 10 millimeter of mercury during inspiration. That is called pulsus paradoxus. है त? Inspiration map fall हुन्छ तर it will be less than 10 millimeter of mercury. Okay, so if it is more than 10 millimeter of mercury, then that is called pulsus paradoxus. Okay, so mark rate, JBP, hypertension, pulsus paradoxus, and oliguria, these are the features of cardiac tamponade. And sometimes a patient who has loculated pericardial effusion, they may present with atypical presentations as well. Okay, So this were the clinical feature. Change in the clinical features once the patient of acute pericarditis develops pericardial effusion. Okay. So what are the investigations then? Echocardiography, ECG. Okay, first of all, we'll be talking about ECG. Okay, so in ECG, we have to see the amplitude of the QRS wave. Okay, I think all of you know different waves of this ECG. Okay, so I think it has already been taught in your physiology in first and second year. So you have to focus more on the QRS complex. And if the patient has pericardial effusion, the voltage or the amplitude of the QRS, it may be reduced if the patient has large pericardial effusion. Okay, so this is also called low voltage ECG. But some of the patient may also have electrical alternates. Okay, so electrical alternance. Okay, so in electrical alternance, what will be there is there will be QRS complex which may alter in amplitude with each beat. Okay, so generally in each beat, the amplitude of the QRS, it should be equal. But if the patient has large pericardial effusion, okay, so the amplitude of the QRS, it varies with each beat. And it is generally because of to and fro motion of the heart within the fluid-filled pericardial sac. Okay, so this was the ECG changes. The other investigation that we can do is echocardiography. It is the definite investigation and is helpful in monitoring the size of the effusion and its effect on the cardiac function as well as presence of cardiac tamponade. Okay, so the other thing we can do is increase this chest X-ray where we can see the increase in size of the cardiac salute. Okay, and there is large effusion and this is also called bottle appearance. Okay, water bottle appearance. Okay, okay, so this is the echocardiography of a patient who has pericardial effusion. Okay, so you can see this is left atrium, left ventricle, this is the left parasternal view. Okay, aorta, right ventricle, and this is the pericardial sac. Generally there won't be any fluid here. Okay, but you can see that there is pericardial fluid in the pericardial sac. Okay, so this is regarding the echo, and this is the ECG showing electrical alterance. Okay, electrical alterance, what I said just now. Okay, so we have to focus more on the QRS complex. Okay, so this is QRS complex, this is other QRS complex, this is other. If you see the amplitude of the QRS complex, okay, so generally if a patient is in sinus rhythm, if the patient does not have effusion, the amplitude of the QRS complex, it should be equal in each beat. But if the patient has large pericardial effusion, the amplitude, it increases and decreases. Okay, so it alters with each cardiac cycle or each beat of the heart. Okay, so this is called electrical alterance. So the other investigation, aspiration of the pericardial fluid. It should be analyzed for red and white blood cells, cytological studies, culture should be obtained, and presence of DNA of Mycobacterium tuberculosis determined by PCR strongly supports the diagnosis of tuberculous pericarditis. There may be role of this CT thorax and MRI thorax. And this may be superior to echocardiography if we are suspecting of this loculated pericardial effusion, if you are suspecting pericardial thickening, and if we have to identify any pericardial mass. Now for the treatment of pericardial effusion, pericardiocentesis. Okay, so it is indicated when large effusion causes hemodynamic compromise or cardiac tamponade. It involves inserting a needle under echocardiographic guidance medial to the cardiac apex or below the gymphoid process directed upward towards the left soldier. But We have to be very careful regarding the complications. During the procedure only, the patient may also have different kinds of tachyarrhythmias, atrial and ventricular arrhythmias. There can be damage to the coronary artery, and there can be bleeding with exacerbation of the tamponade as a result of injury to the right ventricle. There may be some role of surgical drainage when the tamponade is due to cardiac rupture or aortic aneurysm, or if the patient has a viscous, loculated, and recurrent pericardial effusion. Okay, so these are only the indication for surgical drainage. Now, shortly regarding this pericardial tubercular pericarditis, it may complicate pulmonary tuberculosis or may also be the first manifestation of the infection. The condition typically presents with chronic malaise, weight loss, or low-grade fever. And effusion usually develops and the pericardium may become thick and unyielding, uh, uh, leading to pericardial constriction and tamponade, and associated pleural effusion is often present, and diagnosis may be confirmed by aspiration of the pericardial fluid and direct examination or culture of the tubercular bacilli. For the treatment, antitubercular therapy and 3 months course of prednisolone will improve the outcome. Now we'll be talking about chronic constrictive pericarditis. Okay, so this is progressive thickening, fibrosis, and calcification of the pericardium. And in this chronic constrictive pericarditis, and this heart is situated in the solid shell and cannot fill properly. And this calcification, it may extend into the myocardium, also impairing the myocardial contraction. So the etiology, it may be acute or relapsing viral or idiopathic pericarditis. It may be following trauma with organized blood clot. It may be following cardiac surgery of any type or mediastinal irradiation, purulent infection, histoplasmosis, neoplastic diseases, rheumatoid arthritis, SLE, chronic renal failure treated by chronic dialysis. Okay, so what are the clinical features then? The symptoms and signs of systemic venous congestion may also be there, may be there. Okay, so which is the hallmark for constrictive pericarditis. The patient may also present with atrial fibrillation, and presentation with ascites and hepatomegaly may confuse us with some liver problems. Okay, so we may be thinking that the patient has chronic liver disease. We may be investigating the patient in a line of chronic liver disease in these patients. Okay, so breathlessness, they may not be the prominent symptom because the lungs are not so much congested, and this should be this constrictive, chronic constrictive pericarditis. Okay, it should be suspected in any patient with unexplained right heart failure with a very small heart. Okay. So the patient will have right heart failure, but the size of the heart, it will be small. Okay, so what are the clinical features? The patient will be very fatigued. There will be very rapid low volume pulse. There will be elevated JBP with rapid wide descent. Okay, so it is because of filling up. So this why. So do you know about different waves in JBP before we talk about this rapid wide descent? Do anyone of you know about different waves in JBP? Pratik?
No, ma'am.
You don't know. Okay, so you have to know about different waves of JVP, okay, before we talk about this Y descent, X descent, okay. A, C, and V are the waves, okay, these are the upstrokes, and X and Y are the descents. Okay, so there are different conditions in which there will be changes in these upstrokes and downstrokes, different waves. Okay, so before we talk about this, I think it would have been better if we had some class. But since you are not having any bedside classes, you may not be knowing about different waves of GBP. But can you just read the things in your uh, this macloids you have? All of you have macloids? Any one of you, do you have macloids?
Yes, ma'am. तर
No,
hostelमा
hostelमा.
छ
त्यो
म्याम मेरो
JBP को different waves चाहिँ जुन बुकमा पनि हुन्छ कि you can see it in Davidson or in Harrison if you have, or it is very nicely explained in macloids as well. है एक्चुअली त्यो हेर्ने है किनभने मैले JBP पढाएर बस्यो भने त it will take around half an hour है
हुन्छ म्याम
है त ल अब एलिभेटेड JBP हुन्छ with rapid Y descent है त अब तिमीहरूले after you read JBP, okay, so you have to read about different abnormalities in different waves of JBP, okay, so at that time you have to again read about this rapid Y descent, okay. JBP चाहिँ आज गएर सबैले हेर्ने है त. And then there will be loud early third heart sound or pericardial knock. Okay, so you have to know about this pericardial knock as well. Okay? So it is an early third heart sound which is heard with abrupt cessation of the ventricular filling. Okay, so यो constrictive pericarditis हुँदाखेरि चाहिँ के हुन्छ सेल जस्तो हुन्छ नि त हैन त्यो पेरिकार्डियम त्यसैले गर्दाखेरि चाहिँ there will be abrupt cessation of the ventricular filling, and this produces the sound. This is called pericardial knock. Okay, so this is very diagnostic of constrictive pericarditis. Pericardial knock, it is diagnostic of constrictive pericarditis. Okay, so along with that, the patient will also have a small sign, which is the paroxysmal rise in JBP during inspiration, hepatomegaly, ascites, peripheral edema, and pulsus paradoxus. Okay, so what are the investigations we'll do? Okay, so X-ray, CT, echocardiography, all will show features of pericardial calcification. Okay, so in echocardiography, along with the pericardial calcification, we may be able to see the pericardial thickening, dilatation of the inferior vena cava, hepatic vein, and a sharp halt in ventricular filling in all early diastole with a normal ventricular systolic function and flattening of the left ventricular posterior wall. Okay, so most important thing you have to know is pericardial calcification. So for the treatment, medical management is done by managing the heart failure using the loop diuretics, aldosterone and antagonists like spironolactone. Sometimes surgical resection may also be required, okay, of the diseased pericardium. This causes the dramatic improvement in the patient, but since it has the high mortality, so the results, they are very disappointing. Now, lastly, regarding the cardiac tamponade, okay, so cardiac tamponade, it is the accumulation of fluid in the pericardial space. So both pericardial effusion and cardiac tamponade, they are accumulation of fluid in the pericardial space. Okay, but if the patient has hemodynamic instability, okay, so the patient has cardiac tamponade, and if the patient is hemodynamically stable, then that may be pericardial effusion. Okay, so the accumulation of fluid in the pericardial space in quantity sufficient to cause serious obstruction of the inflow of the blood into the ventricle, resulting in cardiac tamponade. Okay, so the amount of fluid, it is not necessary that the amount should be very large. Okay, so if it develops very rapidly, only 200 ml of fluid may be sufficient to develop cardiac tamponade. Okay, so the amount of fluid may be as small as 200 ml when the fluid develops rapidly, and as much as more than 2 liters in slowly developing effusion when the pericardium has had the opportunity to stretch and adapt to an increasing volume. Etiology, it may be because of any form of pericarditis, but common in pericarditis, which is idiopathic, caused by malignant disease or by blood in the pericardial space following trauma, or by rupture of the free wall of the myocardium following myocardial infarction. Okay, what are the features of cardiac tamponade then? The patient will have dyspnea. Some of the patient may also collapse. They will have tachycardia, hypertension, gross elevation of JBP, and the heart sounds will be very soft and faint with early third heart sound, or the early third heart sound. Okay, and pulsus paradoxus may also be there, which is a large fall in blood pressure during inspiration when the pulse may be impalpable, and there can be Kussmaul sign, which is the paradoxical rise in JBP during inspiration. So pulsus paradoxus, I thought this could be very helpful for you. Okay, so during inspiration, lung expands and there will be increased venous return. The right ventricle, it enlarges, and this right ventricle, because of the right ventricular enlargement, the septum is it pushes the left ventricle. Okay, and this will lead to decreased filling of the left ventricle, which will decrease the stroke volume and the pulse amplitude. Okay, so this causes the paradoxical pulse. Okay, so one can detect the beat on cardiac auscultation during inspiration that cannot be palpated at the radial pulse. Okay, during inspiration, you can see the heartbeat during cardiac auscultation, but you may not be able to feel the radial pulse when you are doing it simultaneously. The conditions includes obstructive lung disease, cardiac tamponade, constrictive pericarditis, vena cava thrombus, and pulmonary edema. Okay, so these are different clinical features in patient who has cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy. Since all the features they are overlapping and sometimes very confusing, okay, I thought this could be helpful for you. Okay, pulsus paradoxus, it will be there in all three cases, but it is more prominent in cardiac tamponade. Changes in JBP, prominent Y descent will be there mostly in constrictive pericarditis, less commonly in restrictive cardiomyopathy. Okay, prominent Y descent will be there in all three, but will be more prominent in cardiac tamponade and restrictive cardiomyopathy. Kussmaul sign will be there in all, but more prominent in constrictive pericarditis. Third heart sound will be there in restrictive cardiomyopathy, and pericardial knock, it is the diagnostic of constrictive pericarditis. Okay, so there is a term called Bake's triad. Okay, so the three principal features of cardiac tamponade are hypertension, soft or absent heart sound, and jugular venous distension or JBP with a prominent X descent but absent Y descent. Okay, so since you don't know this different waves, okay, you have to go and read about the main wave first. Okay, so as I've said, there will be A, C, and V wave, two descents, X and Y, and in cardiac tamponade there will be very prominent X descent but absent Y descent. Okay, so this is diagnostic of cardiac tamponade. Okay, and you have to know about this Beck's triad. Okay, for the investigation, ECG may show features of underlying disease. So what is the cause for this cardiac tamponade? We can get the ECG changes of that disease, such as the ECG changes of pericarditis or acute myocardial infarction. In both, there will be ST segment elevation, but convexity in one and concavity in the other. When there is a large pericardial effusion, ECG complexes are small and there may be electrical alterance. Okay, electrical alterance or low voltage ECG may be there. Chest X-ray, it may show an enlarged globular heart, and echocardiography. Okay, so in echocardiography, if we see the right ventricle and the right atrium, okay, so it collapses during the late diastole. Okay, so diastolic right ventricular collapse we can see. Okay, so this is the left ventricle, this is the right ventricle, so, and this is the left ventricle, left atrium, right atrium, right ventricle. And there will be diastolic collapse. You can see the collapsed right ventricle during the diastole. Okay, so this is the echocardiographic finding in a patient who has constrictive pericarditis. And for the treatment, cardiac tamponade is a medical emergency when the diagnosis is confirmed. Percutaneous pericardiocentesis should be performed as soon as possible, which usually shows dramatic improvement, and surgical drainage may be required in some of the cases. Okay, so I'll be asking few questions to you as well if we have time. We still have 10 or 15 minutes. Okay. Okay, so pericardial knock is present in, it is very simple. Okay, so any one of you?
Constrictive pericarditis.
Constrictive pericarditis. Okay. Okay. Okay, good. The second one, okay. Electrical alterance is a feature of dilated cardiomyopathy, pericardial effusion, acute myocardial infarction. So this, there is spelling mistake, okay. Infarction. And constrictive pericarditis. What's the answer?
Pericardial effusion.
Susna,
Pericardial
what is the
effusion.
answer? Pericardial effusion. Okay, so is if the option is uh, cardiac tamponade, okay, so it can be cardiac tamponade as well. Okay, so pericardial effusion or cardiac tamponade is the answer. Okay, pericardial effusion. Okay, the last question. Okay, 45 years old female present with dyspnea and exertion for last 4 months. She denied chest pain but has noted significant accumulation of fluid in her abdomen, and she also complains of lower extremity edema. She has a history of tuberculosis during childhood, which was treated with the 4-drug regimen. Electrocardiography so normal sinus rhythm without any other abnormalities. CT of the chest is obtained and showed pericardial calcification. Okay, pericardial calcification on CT. And during examination, there is raised JBP with pericardial knock. Which of the following is likely to be found on physical examination? Okay, so with this, what do you think is the diagnosis first? Pericardial calcification,
Constrictive
pericardial
pericarditis.
knock.
Constrictive.
Okay, constrictive pericarditis. Okay, so what other physical finding you'll get in this patient? I'm still editing it. So double systolic apical impulse on palpation we get in patient who has hypertrophic cardiomyopathy, right? Canon A wave in JBP we get in a patient who has complete heart block. Opening snap on auscultation we get in a patient who has mitral stenosis. So rapid Y descent in JBP. So since we did not talk about in detail about JBP, you may not be very confident regarding the answer to this question. Okay, so the answer is, what is the answer?
Rapid Y descent in GBP.
Okay, so you go and okay, you don't have to go. Even you can sit in your home, okay, and just you read. Okay, so we still have 10 minutes left, right? So in that time, you utilize your time, read JBP. Okay, is that okay?